Hi, today we'll be talking about reflex inhibition. This is a neurophysiological state that seems to be caused by reduced proprioception, or inadequate proprioception might be a better term. I think the observation has been around for some time, but it was popularized by the Australians when they were working on segmental instability 15, 20 years ago, I would guess now. They made a nice job of both by putting on a more formal basis. Don't completely agree with all of their conclusions, but it's a very nice concept put together nicely. And my quibbles, some a little bit more than a quibble, I'll bring up as we go through this. So it's an important concept. I think it probably has more profound clinical consequences than does segmental facilitation. So like segmental facilitation, it's worth your while taking the time to learn this. It's going to be increasingly important as we go through the next 4 modules as far as etiologies are concerned. Without this, you're going to run into problems actually using the information as best you could. Okay, definition. This doesn't have the same degree of history or research that segmental facilitation does. I say most of this is observational, but it fits together nicely with what we see clinically and what we can do with it. So it's inhibition of the muscles around the joint that's causing the inhibitions due to inadequate proprioception. Causes reduced proprioceptive input. As I mentioned when we were talking about segmental facilitation, this produces almost the opposite of what segmental facilitation does. So it's difficult to see how this can also be a cause of segmental facilitation. Even hypermobility, which has an increase in physiological range, still results in inadequate proprioception, simply because while the range has increased, the proprioception hasn't, and it may even have been reduced as the ligaments in cats become attenuated. So for the given range of motion, there's less proprioception than it should be. So you end up with reduced proprioception. And of course, instability and hypermobility is self-explanatory. The distribution of this is local to the joint that's causing it. This is not segmental, this is not global, and it's not even regional. This is local to the joint. You won't see the effects of this, the immediate effects of this, further away than the muscles overlying this joint. So the effects are striated muscle hypotonia. I'm not going to talk about smooth muscle because I have no idea if it affects smooth muscle or not. I haven't seen any vascular effects with this, but there may be, I don't know. So we're going to concentrate on striated muscle. So you have hypotonia. That hypotonia can be quite profound and almost certainly will result in neutral zone increase. So neutral zone instability that can then progress to end zone instabilities, such as segmental instability and articular instability. There's the other major effect, and the one that's easiest to find, is breaking weakness of the muscles around the joint. Now, this breaking weakness is patterned. It's quadrant pattern or a PNF pattern, but it's patterned. In the spine, for example, you'll find one rotation is breakingly weak, and it's breaking, I mean, you push on it, it holds, and it suddenly gives to put through it. The best way of feeling this is with an eccentric contraction from the end of range. So you'll pick up breaking weakness, and it is patterned. So if it's right rotation, for example, you'll find that right rotation and extension, or right rotation and flexion has the same breaking weakness. If the segment's unstable in more than one direction, or if 2 segments are involved, then you find that breaking weakness in 2 quadrants or more. So again, this is going to lead to instability, but now, because you can't protect the joint at its end ranges, this is likely to lead more to end zone instability directly. It's also going to use to tendon and muscle overuse because they are weak and they're trying to do their job, and so you end up with degenerative tears and tendinoses. You're left with ligamentous instabilities, arthropathies, tendinosis, and muscle tearing, degenerative muscle tearing. The other effect of this is probably indirect from the previous two, and that is atrophy. If the muscle is actually atrophied. Now they found this on the spine with MRIs. In a lot of instances, the local muscle, the multifidus, for example, will become atrophied. You'll lose muscle bulk, and that muscle bulk is replaced with fat. And this will lead to permanent instability and other defects from this. So, and I say permanent now because trying to correct atrophy means you've got to do high load, low repetition exercises to stress the muscle. And given that this is over a joint or in the spine that's already dysfunctional in the child, so you won't be able to do those sort of loads. So you can't hypertrophy an atrophied muscle because the patient's spine isn't good enough or the joint isn't good enough. You can try, but it's unlikely you're going to do it. So this is what I'm saying, it will lead to permanent effects that you wouldn't see with segmental facilitation. Atrophy is a very real thing, and up to 50% of the spinal muscles can be lost and have been shown to be lost on MRI. We'll talk about the assessment of this when I'm finished with reflex inhibition, and we'll combine segmental facilitation, reflex inhibition, and the biomechanical exam of the spine all in one go. As far as treatment is concerned, this one's really quite simple. Find and treat the cause. It's that simple. There's no point in trying to, apart from testing procedures where you can use this to find out what joint is causing it. As far as treatment is concerned, deal with the cause of the reflex inhibition, and that should correct the reflex inhibition. If there's atrophy, you can try strengthening, but I don't know how much success you're going to have doing this simply because of the pathology that's present. You can also use these patterns to rehab these affected ranges. So they lend themselves very nicely to PNF techniques because these are lost in PNF patterns. So it's not a matter of strengthening the muscles now, it's about rehabilitating these ranges. So there's reflex inhibition, much simpler in concept, simpler to understand. It's when you combine the two, because it's very possible to have both segmental facilitation and reflex inhibition existing at the same time. You'll see the segmental effects of reflex inhibition, but at the joint, it's likely that segmental facilitation over the segment, but at the joint, it's likely that the most obvious signs will be of reflex inhibition. This varies a little bit, but that's been my experience. That segmental facilitation is dominated locally by reflex inhibition, and trying to sort these two out can be a little difficult, but we'll try and make it as clear as possible, not as simple as possible, but as clear as I can to help you go through the process of deciding which is more important. Not even that, actually. Well, how are you going to treat what, where, and how you're going to rehabilitate both. In both cases, it comes down to treating the cause, but the cause is variable, especially when you're looking for etiologies.